The influx of sodium ions or the efflux of potassium ions during the repolarization can be measured in what's called an electrocardiogram or an ECG, or the German, which is actually EKG, to actually measure this current as it's being generated by the flow of sodium ions into cardiac cells, or potassium ions, once again, flowing out of the actual cardiac cells itself. It's divided up into different regions. You have a P wave, you have a QRS complex, and then you also have a T wave, and then there's different intervals and segments associated with the actual electrocardiogram. It's typically taken by hooking up electrodes to the arms and legs and forming what's called Einthoven's triangle around the actual heart. That's EINTHOVEN, Einthoven, and that's how it's typically measured. There are 3 lead EKGs, 6 lead EKGs, 12 lead EKGs. The more electrodes that you have, the better the actual picture of the electrical conduction around the heart. The baseline measures time in milliseconds, or thousandths of a second, while the y-axis actually measures voltage in millivolts, or a thousandth of a volt. The P wave, which is a small upward flexion, actually is formed when the SA node fires, causing the atrial depolarization. Sodium ions are rushing in, and this is reflected as a small upward flexion on the EKG. We also refer to this as atrial systole. The QRS complex starts with a small downward flexion as the AV valves slam shut with an increase in pressure within the ventricles. This is followed by an increase, an upward flexion called an R wave, with an increase in pressure as the ventricles start to contract, or what we call ventricular systole, followed by a small downward flexion called the S wave, when the actual semilunar valves now contract with the afterload and the pressure increasing on the actual semilunar valves. The atrial repolarization is also occurring, and you can see this on 6 and 12 lead EKGs, but it's masked actually in a 3 lead EKG by the QRS complex, which is a stronger depolarization. Then you have the T wave, which is the ventricular repolarization, which is shown when the actual potassium is released from the cells, causing an increase in charge and a small upward flexion that we call the actual T wave in the EKG. And this picture, which is also shown on page 735 of your textbook, shows a normal EKG, and it shows you some of the intervals and segments that you should be concerned with. The PQ interval, which is from the beginning of the P wave, when the atria first begin to depolarize, to the Q segment, which is when the ventricles begin to depolarize, should be about 0.2 seconds or 200 milliseconds in a normal individual or person with a normal PQ segment. Anything greater than 0.2 seconds may indicate damage to the conduction pathway. The ST segment, which marks the end of the S wave and the beginning of the T wave, is another important segment. And with the ST wave, if it's elevated above the baseline, it may indicate an acute myocardial infarction. And if it's depressed, what we call an ST trough, it may indicate a hypoxia or a insufficient flow of oxygen. And in some cases, this can be explained during stress tests, where the individual is being put through a greater amount of rigorous exercise. I like this figure. It's a figure that's also shown in your textbook on page 737, where it talks about the correlation of the EKG waves. You can see in this figure with number 1, with the formation of the P wave, the atria are depolarizing. You can see that in number 2, the time when it slows down, the signal is slowing down when it hits that fibrous skeleton between the atria and the ventricle. Number 3 is showing you the beginning of your ventricular depolarization, that QRS complex. Number 5 is showing you the time after the contraction of the ventricles and leading up to the repolarization, that ST segment. And then number 6, of course, showing you the T wave, where you have the release of potassium and that repolarization. So this is a really nice figure to kind of illustrate a electrocardiogram. EKGs are very good for diagnosing different types of abnormalities with either the conduction of the heart or also with the heart itself. You can diagnose damage to the conduction pathway, prolonged PQ intervals. You can also diagnose in heart enlargement, enlarged P waves, in atrial enlargement, maybe through something like a mitral valve stenosis, where you have a stenosis of the mitral valve leading to an increased left atria. It can also indicate electrolyte or hormone imbalances. If you have an elevated T wave, it may indicate a hyperkalemia or a high level of potassium. So there's a lot that you can see with an EKG. It's very good at diagnosing these different types of abnormalities. Myocardial infarctions, for instance, are another type of abnormality that can typically be seen in an EKG. These are some examples of EKGs, and this is to illustrate just a normal sinus rhythm where you have a contraction about every 0.8 seconds for about a 75 beats per minute sinus rhythm. And in the lower picture, you can see a nodal rhythm where you have the absence of the actual P waves, so there's no SA node activity. Instead, it's being carried actually by the AV node. And so, it's a slightly different rhythm in that particular case. These are some more EKGs. The upper EKG there is showing you a arrhythmia, what we call a second degree bundle block, characterized by the multiple P waves that you can see before you have a QRS complex. And below you have a ventricular fibrillation, which looks like a squiggly line. If you saw the heart with this ventricular fibrillation, the chambers aren't adequately filling with blood, and the heart resembles something of a bag of squirming worms. Cardiac disorders, if the impulse isn't reaching the ventricles from the atria, you may have a bundle block, which results in no QRS because the signal isn't reaching the bundle of His and being propagated up through the Purkinje fibers. Obviously, this can lead to death. Different things can cause damage to the actual conduction system: cardiac arrest, your cardiac thrombosis, which can cause a lack of oxygen and death of the tissue, what we call a myocardial infarction, as the tissue is deprived of oxygen. Like any tissue, it dies out. If this dead tissue is part of the conduction pathway, it can lead to a bundle block. These cause about 1 million deaths a year. Cardiac output, simply put, there is none because the ventricles aren't contracting, so your cardiac output drops. And then we have to also be aware of that closing pressure. If cardiac output drops, then our blood pressure also decreases. And if it drops below 44 millimeters of mercury, our closing pressure, then our arteries close, collapse. There's also a phenomena that is referred to as the ST trough, and it can tell you if you have a cardiac ischemia, if it goes below the baseline, or in some cases, if it's elevated above the actual baseline, it can be indicative of a myocardial infarction. So if you see an ST trough and you're not doing anything physical, that's not a good sign because it means that your heart's not getting enough oxygen. Heart rate can be measured by taking a pulse. You can take a radial pulse at the radial artery or a brachial pulse at the brachial artery, or you can take a carotid pulse at the carotid artery, or you can take a femoral pulse at the femoral artery. So there's many different places in which you can measure heart rate. And now it's established by the SA node, which causes the heart to contract. And in infants, a heart rate of 120 beats per minute is normal, or even higher than 120 beats per normal is normal in some cases. Young adult females, on average, somewhere between 70 to 80 beats per minute, and young adult males, 64 to about 72 beats per minute on average. Heart rate does tend to increase as we get older. This is statistically been shown. Two different conditions I'd like you to know. One is called tachycardia, and that's a persistent resting heart rate in adults greater than 100 beats per minute. Things like stress or anxiety, certain types of stimulants, drugs can increase heart rate. Heart disease, where the heart has to work harder, all these things can increase heart rate. Increased body temperature, where it causes your heart to beat faster to get rid of more of that hot blood. The bradycardia, This is a persistent resting heart rate lower than 60. Not uncommon in endurance athletes, okay, where we see an increase in stroke volume, which accounts for a decrease in heart rate. So some athletes have a lower heart rate